So it's my pleasure to introduce my dear friend Horace working actually in Rome, and he's going to talk about the prevention of the adhesion and what the evidence-based data we'll have right now.
Okay, thank you very much, Nicola. And I want to start by a special thank to Michel Canis and to Nordic Pharma for inviting me and for giving me the opportunity to speak about, to share with you some opinion about the clinical benefit of anti-adhesion agents and the lack of evidence-based data. So I have a free conflict of interest during the last 6 years. And I propose you to start by having a look at available evidence-based data concerning the use of anti-adhesion agents in our surgery, in gynecological surgery. And here you have a recent Cochrane review where the authors tried to evaluate the effectiveness of barrier agents used during the pelvic surgery with clinical outcomes, meaning the pain, the live birth, and the postoperative adhesions. And they checked data from 18 randomized controlled trials involving more than 1,200 women, and they observed that no studies reported data on clinical outcomes such as pelvic pain and live birth. And 1 year earlier, the same team analyzed data from randomized trial concerning fluid and pharmacological agents for adhesion prevention after gynecological procedures. And they observed that gel and hydroflotation agents appeared to be effective in preventions of the adhesions. However, there are no data about the clinical impact on this adhesion prevention, meaning on pelvic pain and fertility. And they concluded that further research are required, absolutely required in this area. And now this is very embarrassing because if we use anti-adhesion products, it's specifically for getting better the patients and for improving the fertility rate. And let's try to understand why we have this lack of strong evidence in this specific field. And let's try to imagine that today you're together here and we decide to plan a randomized trial to evaluate the impact, clinical impact of the use of anti-adhesion barrier in endometriosis surgery. And will involve only surgeons who take care to use 100% of surgical measure to prevent adhesions, humidification, low pressure, good hemostasis. And we'll randomize the patient, gel or other anti-adhesion product versus nothing. And we can study 4 main outcomes: the postoperative adhesions, the pain, the fertility, and the complication related to adhesions and the cost. And it is obvious that we cannot plan a randomized trial able to answer all these outcomes because each outcome has a different frequency, so each outcome requires a different sample size. So let's try to have a look at each outcome. The first one is the most simple. To assess the prevention of adhesions, it is enough to wait for some weeks and to perform a second look laparoscopy, and this is the design of the majority of randomized trials available in the literature today. So we need less than 100 patients, and we need to wait for some weeks in order to perform a second surgery and to prove that using anti-adhesion products may reduce the formation of adhesions. Now let's have a look at the second outcome, which is a clinical outcome. And the question is, are the patients receiving the anti-adhesion products doing better than those without anti-adhesion products, and we'll assess the pain assessment. We have to wait for 6 to 12 months in order to evaluate this outcome. The problem is that we have no precise idea about the difference that could be expected between the two arms. We have no data. We may have a look at the randomized trial from Holland, where adhesiolysis was assessed, a randomized trial published in Lancet in 2003, I think, where there was an arm with adhesiolysis and an arm with only diagnosis laparoscopy. And they observed that the difference in pain improvement was as little as 15 to 35%. And this lack of the power of the study was probably due to the reformation of adhesions or the small participation of adhesions to the pain mechanism. It means that if we expect that only 15% of benefit in terms of pain, we need a randomized trial much more larger. We need 200 to 300 patients followed up for 1 year. If we try to prove that there is a fertility improvement, we need to wait for more long time in order to let the patients the time to conceive. Here, we have no idea about the difference that we can expect using an anti-adhesion barrier. And we can have a look at data in the literature to have an idea about the rate of pregnancy after the surgery, for example, for endometriosis by cystectomy. And if you have a look at this study of Paolo Vercellini, we can see that about 50% of patients may be pregnant after the cystectomy. And maybe if we can prove that using the anti-adhesion agents may increase the rate by 10 to 15%, it might be clinically relevant. We published 2 years ago a study where we compare ablation using plasma energy to cystectomy in patients managed in Rouen and elsewhere. And we observed that in Rouen we used threefold more frequently the hyalu barrier. So we may have a look at the postoperative pregnancy. However, there are numerous confounding factors because in Rouen we have the patients was older, with more frequent preoperative infertility, with twofold more frequent bilateral cyst, rectum involvement, deep endometriosis, threefold more frequent colorectal resection. So all these outcomes will jeopardize the analysis of the impact of the anti-adhesion barrier. So we need a randomized trial. However, if we expect that the difference, a benefit in terms of pregnancy, would be 10 to 15%, we need more than 200 evaluable patients in each arm, followed up 2 to 4 years. So the trial becomes very, very expensive. And now if you want to prove a decrease of intraoperative complications or costs related to the use of anti-adhesion barriers, we may have a look at previous study based on the Scottish National Health Service database, where several authors try to estimate the rate of reoperation or complication related to adhesions. And in this study where the patients had open surgery and were followed up 10 years, the authors conclude that maybe 5% of patients had complications directly related to adhesions and 4% had a secondary surgery. And the same study regarding the children observed that between 1% and 4% of complications may be related to adhesions, and this rate is very, very low. And if you have to understand the impact on the cost, we can use this paper from colorectal disease, where the authors try to estimate the benefit and the balance cost-benefit. And they concluded that anti-adhesion product, which price is 300 euros, should have an efficiency more than 60% to become interesting from a point of view economical, while not an anti-adhesion product which price is 130 euros may have lower efficiency around 25%. At all this data make us realizing that the reduction of readmission for complications related to adhesions by 50%, meaning from 5% to 2.5%, requires almost 1,000 patients in each arm, followed up for 5 to 10 years. It means that this trial is wonderful, but it's so expensive, and I wonder if it is really feasible a day. So I think that we won't have in the next future randomized control trial focusing on clinical outcome, and to plan such trial we have to handle with several factors. We have to choose a disease with a high risk of adhesion formation, such as endometriosis or myomectomy. We have to focus on young women in order to have a good pregnancy rate. We have to focus on to evaluate the pain. We need diseases with a low probability of postoperative pain, except that due to adhesions. So endometriosis would not be a very good model. We have to keep in mind that randomized trial data we discussed or provided by studies where the patient were managed by open surgery, while now you use the laparoscopic surgery, so the rate of the adhesions is even lower, meaning that the sample size will increase. Also, the surgeon's skill and technique is a major factor which confound the outcome, because if the surgeons use a worse technique, do not humidify and use a high pressure, maybe the rate of adhesions is higher, so the sample size will be increased. And last but not least, we have several types of anti-adhesions products: gel, fluid, solid, and it does not mean that a trial using one agent provide data extrapolable to other agents. So I wonder if we need a randomized trial for each one of these agents. However, large randomized trials are possible, and this is wonderful. This one is the trial of Beck in disease and colorectum, involving 1,700 patients managed for abdominal surgery, where the authors tried to assess the risk of fistula or anastomotic leakage when the anti-adhesion agent, which was ceprafilm, wrapped the bowel anastomosis, and they show that the rate of fistula is increased sixfold. And this trial allows us to state that anti-adhesion agents should not be placed around the colorectal suture in patients with bowel endometriosis, and this is the first level of evidence conclusion. So in conclusion, we know today that anti-adhesion products are efficient in the prevention of adhesions. However, we have no idea about the clinical efficiency, the impact on the fertility and pain, and this is simply because the randomized trial with these clinical outcomes is difficult to perform. However, difficult does not mean impossible, and I am sure that we'll finish by doing this kind of randomized trial. Thank you very much, and thank you Nordic Pharma for the opportunity for free exchange of opinion.
Thank you very much. All right, I think we are running very, very late, so we're not going to have time for questions. We can just conclude this is all good news for surgeon, because finally adhesion and consequences is based also